I'll tell you a secret. You are the luckiest here, because this is going to be the best session. Forget what you've heard till now. This is the real ophthalmology. And of course, Professor Prudes, a lecturer, after all. So, I would like to introduce Amanda Churchill, Dr. Amanda Churchill, or Mrs. Amanda Churchill, according to the British Miss Amanda. The surgeons in England and in UK are called Mr. and Miss and Mrs. So Amanda, above all, is a very good friend, very good scientist, very good mother, and a very beautiful woman. So she's a senior lecturer in the Bristol University, in the eye department there. Am I right? Yep. And she's dealing with pediatric cases. She's a pediatric ophthalmologist and with a special interest in inherited retinal diseases. So she's going to be a star, as I promised to her. And because I'm lazy, I'll sit there doing a few comments. And if there is more time at the end, so I'll go through some short cases for you. Okay? Amanda?
Thank you, Nikos, for that very kind introduction, and thank you for inviting me. This is a lovely place, and it's my first time in Thessaloniki. I'm interested that at lunch, I was having lunch with a couple of people I'd never met before, and I said to them, this session, you're going to be asked questions. It's different to this morning. I'm going to ask the audience for much more participation, and they've disappeared. You can see it, they're not here now, so... So it's going to be up to you now. You can go if you want, but... So the first thing I want is, and please do shout out, otherwise Nikos is going to pick on people. And so collectively, what do you see? What is the pathology that you can see here? Anybody? Oh, somebody said it, heterochromia.
Yeah.
Now we've told you, you can probably see it. I chose a picture that was not quite as barn door obvious, but hopefully you can see that. So can you shout out some of the causes of congenital heterochromia?
Any idea, Chrysanthi, what do you say? Any possible cause of heterochromia, congenital one?
Okay, so malignancy is a possibility, but is quite low down.
Cyst?
A cyst, okay. Again, I'd say not so common. Can anybody think of anything else that they would?
Horner
Horners,
syndrome,
yeah, we
yeah.
see quite a lot of Horners. Typhi? Ah, anybody help him out? Where you get a white forelock? Waardenburg's?
Waardenburg syndrome, yeah.
Okay. Anything else? So we've got congenital Horners. We've got, don't forget, Sturge-Weber can give you heterochromia, Waardenburg's, and of course idiopathic. So I'm not going into the rarer things like the melanomas and cysts. These are the more common things that we'd see. So just taking them one by one, what are three other features that you can see, some of them in that picture there of Horner syndrome, that you'd be looking for to make that diagnosis, other than heterochromia? Ptosis, great. Good. You can see, not very obvious, are they? But they're usually there.
Yes, meiosis, somebody
Meiosis,
said,
yes, exactly. And the other thing which I usually just do this on the cheek, just to see if there's anhidrosis, so lack of sweating on the face. So those are three other features that will make that heterochromia into a congenital Horner syndrome. What's the workup that we do? Well, obviously we do a full eye examination. We check for cervical and abdominal masses. We check the other cranial nerves. And we may do a urinary VMA for neuroblastoma. And I'm just going to mention the paper at the bottom here, which was a paper done by a colleague of mine who now works in Dundee called Nick George with Craig Hoyt. And they looked at 23 infants that were under 12 months of age who all had congenital Horner syndrome. And this paper was a very practical paper about, do we actually need to investigate, or how much do we need to investigate these children? Because there's a whole load of things you could do, but do we really need to do them? So they followed them up for a number of years. It was about 7 years, and looked to see what the causes were of their congenital Horners. So of these 23 children, 4 had birth trauma. So that would have come out in the history. So you didn't need to investigate them anymore. 2 had neuroblastoma, hence the VMA that we might do. One of them was already diagnosed with an abdominal neuroblastoma. These are not particularly well children. 1 was a ganglioneuroma of the pulmonary apex, which again could have been picked up on a chest x-ray. So you might consider that, but they're fairly rare. And 16 had no cause. So they were idiopathic congenital Horner syndrome. So if you think about the odds of missing something, it's really stacked in your favour that you're going to not miss a serious condition. So if you just do those, checking for the abdominal and cervical masses, and just check the other cranial nerves, you may not even need to do the VMA, but I would say that was probably the most likely test of an out-of-the-ordinary thing to do. And just to remind you of the pathway, you can have a lesion anywhere from the hypothalamus all the way down the oculosympathetic pathway to the orbit. And some of the causes are congenital varicella, birth trauma that I've mentioned, tumours of the neck and mediastinum. But no obvious cause is your most likely diagnosis.
Yeah, just to comment on that, if you don't mind. So the take-home message is just, if you have a congenital Horner, so you should also go through that workup. Although, in the vast majority of the cases, we come up with nothing. But you still should do that. Okay. Yeah.
So then, Sturge-Weber, you're not likely to miss this because of the port wine stain on the face, but this is another cause of heterochromia. Don't forget that they can have angiomas in their brain, they could present with learning difficulties, and they can have headaches, seizures, mini-strokes. And it's down to an abnormality in the GNAQ gene, so we know the gene that causes it. So we're presented with this child in front of us, and we can make the diagnosis when they walk in the door, but what are the other eye features that we should be looking for? Anybody? What are the things we're worrying about in these children? Yes?
Yeah.
Absolutely. So the intraocular pressure. Why do we worry about the intraocular pressure? What's going on there? That's right. So they get high episcleral pressure, they can have abnormal trabecular meshwork, and they can develop very difficult to treat glaucoma. So we don't want to miss it. So we're checking their intraocular pressure. Is there anything else that these children get? Well, yeah. Let's have a look.
Yeah.
They can get these diffuse choroidal hemangiomas. And the first little hint that they might have this could be when you check their visual acuity, because they may be totally asymmetric, could be unilateral, could be bilateral. So when you check their visual acuity, they may have amblyopia in one eye or apparent reduced vision. You may then refract them and find that they have hypermetropia in that eye that has the choroidal hemangioma. So it may be no more obvious than that, but just think, if you have a child with Sturge-Weber with unequal visual acuities or with hypermetropia, always be looking for that diffuse choroidal hemangioma. And they're not that easy to pick up, as I'll show you in a minute in a picture. And we already talked about the glaucoma. So how do we investigate them? Well, as I said, we check their vision, we refract them, we measure their intraocular pressure, and ultrasound and OCT are helpful if the child's old enough to cooperate. And if we do that, we can see in the top two photographs there how actually normal looking the diffuse choroidal hemangioma can be. It's just a little bit more orangey. You sometimes can see the lipofuscin over it. If you're lucky enough, you'll see a fold, as you can see in the picture there, that might alert you. But when you do the OCT, you can see the thickening, you can see the intraretinal breaks there. So if your child is cooperative enough, that might be a helpful thing to do. So how do we treat the complications? Well, because we don't necessarily need to treat the intraocular pressure unless it goes high. And we don't necessarily need to treat the choroidal hemangioma other than give them glasses. But if their vision is dropping, if they're getting the breaks, if they're getting subretinal fluid, then we may need to give them PDT or external beam irradiation. And the glaucoma, as I said, is very hard to treat, and they usually end up having to have implant devices.
Just to explain that PDT is photodynamic treatment, okay? And may I make a comment on that?
Yes, of course.
Because we had a discussion yesterday with Amanda, and we had actually 2 cases this year with choroidal hemangioma. And I've got pictures, fundal pictures to both children at the age of 5. You couldn't see anything at all. The second case, that's why I'm saying it's very important, because the second case especially, we saw the first child with a very painful eye because of the glaucoma as well. But that wasn't a glaucoma due to the trabecular abnormality or the episcleral high pressure. But that was because he had a detached retina and blocked, and he had angle-closure glaucoma. So we needed to take care of that. But the second one was just last week, 3 days ago. So this guy, 5 years of age, he had hypermetropia and anisometropia. So with the, of course, Starz-Weber, okay? So I checked that. We used to treat him for amblyopia. I had fundal pictures as well. So during the last visit, I've seen twice. So I saw him, and I didn't like something. The hypermetropia was higher, and the visual acuity was reduced instead of the occlusion therapy. So we did OCT. He was extremely cooperative child, and we found that it was hemangioma, and now we take care, and we're thinking what to do next, because he's 5 years old, and I'm not sure if it's going to be if we show him, and are thinking what we're going to do next. So it's very important when we have that, of course, just to check the IOPs, but always remember to see if there is a hypermetropia to one eye, just check carefully what is going on.
Thank you. So this is Typhus condition, the one with the white forelock, Waardenburg syndrome. So this can either present with heterochromia or brilliant blue eyes, as you can see in the second one along in the top there, who has got the white forelock. Sometimes you can miss the white forelock because they may have had their hair coloured. It depends on what age they are when they're presenting to you. So always ask about that. The other thing that really is going to make you think of this condition, if it's not obvious, is the association with deafness. So a large proportion of them have heterochromia and deafness. So be thinking Waardenburg's when you hear that. There are the major and the minor criteria that I've put up there to suggest that to make that diagnosis. And it has been split into 4 different types according to the genes that are involved and also the other associated features. So the most common one is, let me see. Oh, I'm so sorry, I've done it the wrong way. How do I press the...
The top, I think. The top one, no?
That's the one I just pressed. Perhaps it's the middle one.
It's coming.
The middle one.
Yeah,
no, it's fine, it's fine. So the most common one is where you have the PAX3 gene involved. Waardenburg's type 2, there's several genes involved, but they don't have the telecanthus, the widespread eyes. Type 3 is rare, and there they have abnormal upper limbs associated with the deafness and the heterochromia. And type 4 is where they also have Hirschsprung's disease associated with it, so bowel problems. And these are the 3 genes that are associated with that type of Waardenburg's. But probably most of you will see type 1 with the PAX3 gene if you see it at all. So that's another presentation, another cause of the heterochromia. Now, if you saw this young girl and I told you that she was 7, she had a normal birth history, so let's rule out congenital Horner's because there's no birth trauma, no family history, so maybe inherited, don't know, visual acuity is good, she's got good general health, her fundi, when you look at them, are normal, and she's got normal hearing, what would you plump for out of that list that we had at the beginning for the diagnosis? Anybody?
Everything normal, nothing at all, just that.
Don't be worried, it's not a trick.
It's not a trick.
Somebody said idiopathic.
Idiopathic, yes. Yeah.
So remember, sometimes it hasn't got to be anything complicated. It could just be a sporadic idiopathic heterochromia. So these cases happen fairly commonly. I expect those of you in the music business who knew David Bowie, he's had idiopathic heterochromia. So it's out there. So I'm going to move on now to something completely different, which is to do with the optic nerve. Now, I get probably 3 or 4 referrals per week from people in the community who test the children's eyes. We get referrals from opticians because they test as well as prescribe, where they send in children who've got something funny about the optic nerve. Usually it's slightly raised disc margin, suggestion of a blurring on the nasal side of one nerve, otherwise healthy child, sometimes a bit of headaches, and it all stems from a court case where one of the opticians in our community was sent to jail because they missed a brain tumor in a child. So now everybody sends everything into us, regardless of symptoms or signs. We get so many referrals. So this is one case which I have to say, I think everybody would agree is a little bit more than just a vague blurring of one of the margins of the disc. So this is a 12-year-old girl, very common age for us to see, with an unusual right optic nerve appearance with no previous eye problems. What kind of things do you want to ask this child? So we're taking a history. Anybody got any questions that they'd ask? Yeah?
Morning headaches.
Fantastic. So has she got any symptoms? Has she got any headaches? Yeah, so morning headaches in particular. Yeah, anything else you'd want to ask? Yeah, at the back.
Whether this was the first time she was ever being examined.
Okay, yeah, so is this long-standing or is this an acute thing? Yeah, sure. Yeah?
Head injury.
Head injury. Okay, great. You're thinking... Okay, yeah, fine. Yeah, anybody else?
Viral infection.
Fantastic. Yeah, absolutely. So we want to know, have they had a recent viral infection? Could this be a papillitis? Are they diabetic? Have they got any neurological signs? So we talked about that morning headache. Have they had any fits? So we want to just ask them general questions. Have they noticed any visual field defects, or do they know that their colour vision has recently changed? She's 12. She may be able to give you quite a good answer to most of these questions. Is she on any medications? In particular, anybody got any ideas of the medications we might be thinking of here? Not so much antibiotics. It's actually the oral contraceptive pill that can give you benign intracranial hypertension, that can give you swollen discs. So she's 12, she might. So, you know, she's probably gone through puberty and she may have been prescribed it for regulation of her menstruation. And also we want to know, is there any family history? And I'll come on to why that's important. Not just because I ask everybody about family history. So what do you want to do next? Please just shout out. Okay. Does anybody want to look at the other eye? Okay. So we want to go through the kind of normal standard things. We want to know what's her vision like, don't we? We want to know what her colour vision's like. We want to know if her pupil responses are normal. We're looking at an optic nerve here, so we want to do those standard things first. And as you can see, she's got perfect vision, colour vision's absolutely fantastic, pupil responses are normal, and her eye movements are normal. So we always check blood pressure. Really important not to miss this. Anybody that's got potentially papilledema, which it might be, but at the moment we've only seen one swollen optic nerve, we want to know, could this be due to hypertension? So we've seen the one eye, and now we're going to look at the other eye. So now that might change your thought process as to what's going on, because I think you probably agree that the nerve on the left eye is not swollen. Okay, so now we've got a unilateral swollen optic nerve. So that makes us calm down a little bit. We're not panicking about this being papilledema. So what do we do next? Well, I know some people went straight for ultrasound, but I really like Goldman visual fields. Now, I know this isn't Goldman. This is the Humphrey visual fields, but in children, I tend to do Goldman visual fields. And when we audited all our cases of funny optic nerves, we found that the most sensitive test for having intracranial pathology was having a visual field defect. So if they didn't have a visual field defect, they actually didn't have intracranial pathology. And I'm not suggesting that's absolutely the only thing that you should do if you saw papilledema, but I am saying that it's a highly sensitive test. So children can't always do these automated visual field tests, so if they can't, then do the Goldman visual field. And what you see is an enlarged blind spot in the eye corresponding to the swollen nerve and normal blind spot here. This is a fantastic test if you have the availability to do autofluorescence. So what we're seeing here is a normal fluorescing optic nerve on the left side and a little bit of hyperfluorescence here on the right. Somebody asked for an ultrasound. This is the optic nerve with the normal ultrasound reflexivity, and here you've got a hyperreflective area just where the optic nerve is. Do we need any more tests, or have we made our diagnosis now? You said you don't need any more tests. You're quite happy now with your... Don't say what you think it is. Okay, all right, it's a drusen, that's what you feel. Does anybody think we need any more tests? Oh, yes, what do you want to do? Test the parents. Okay, how is that going to change what you might be thinking of? Sorry, shouted? Okay, interesting. It isn't going to necessarily change your diagnosis, is it? Or your management, but it might make you feel more confident about it, possibly?
In the past picture, there was a calcium.
Calcification.
Yes.
Calcification
Yes.
on the optic fluorescent.
Yes.
I think.
Here, yeah. That's why it's fluorescing, absolutely. And then on the ultrasound scan, this is the calcium here that you're seeing, this hyperreflective area. So more tests needed. I'm so thrilled that you didn't just rush in and do a brain scan. So the answer I'm hoping you'll all tell me is that head imaging is not needed. I had a split between my trainees when I asked them. Some of them wanted to rush to do the head CT or MRI. Have you made your diagnosis? I think we've all agreed, yes, we have, with the information we have.
Just a comment, if you don't mind,
Yes.
Amanda. I would agree with you. Yeah, we don't really need to rush to go for MRI. But if there is a symptomatic child, I'm getting the opposite side now.
Yeah.
You've got a symptomatic child with headaches, etc., and you do the tests and you find a drusen, don't relax. Because there is a paper says that 2% of children with drusen could have intracranial pressure as well. But they're usually symptomatic, so that alarms you to go for that. But in this case where there is nothing, there's asymptomatic child, I would agree I think it's unnecessary.
And I think that's important where you've got bilateral drusen.
Yes,
Yeah.
yes.
So nobody mentioned doing an OCT, and this is something that we do routinely, but actually I don't think is necessary. But sometimes we do tests just because we can. And I wanted just to highlight that some of the features that try to distinguish optic nerve head drusen from optic disc edema. So when you do an OCT, so this is the normal nerve of that child, and this is the drusen nerve, and this is a disc edema. Now, you might look and go, oh, how do I tell? But if you actually look at the sort of lumpy, bumpy appearance of this versus the much smoother contour that you have, that is one clue that on an OCT, you're probably looking at drusen. So they tend to have this lumpy, bumpy internal optic nerve contour, and they also have a much more, if I just go back a second, a much more abrupt tapering here than you see here, which if I, oops, sorry, just emphasize there, you get this sort of lazy V sign, which is characteristic of disc edema. Don't totally rely on it, but these are just little clues. So a colleague at the back mentioned that they're familial, and yes, they can be, so it can be helpful to look at other members of the family. Bilateral in about 2/3 of cases. And the thing to remember is that they're 99.999% asymptomatic. So these are healthy children that are just picked up by somebody that goes, oh, I better send you in to have you checked over. And the reason that we see them at the 10 to 12-year-old age is because this is when the drusen have gone from being really buried deep in the optic nerve head to starting to surface. So people start to see the signs of them. You see the calcification typically on the ultrasound test. And certainly when I was training, we were learned to look for trifurcation of the vessels as a sort of pathognomonic feature of disc drusen. And actually, you can see them in disc edema as well. So don't use that as your, and there's a paper to show that. That's just up there as your main thing. The OCT is quite helpful in monitoring optic disc edema. So I said I wouldn't use it necessarily to make the diagnosis of optic nerve head drusen because some of the other tests are more helpful. But where it can be helpful is where you actually end up finding that you've got optic disc edema rather than drusen, and you want to monitor that edema by monitoring the nerve fiber thickness.
Yes, we do that, yeah. We do that because you need to compare if there is just, we usually do. Just to summarize, if you don't mind, it's very important because here in Greece as well, we've got referrals, and sometimes it's so difficult to put a diagnosis or to follow them up. Some children were with known intracranial pressure because the neurologist is asking how about the acetazolamide, how to do to reduce it or not, and to regulate that. And in that case, I would agree, OCT is maybe the best way because we have this image, the vertical cut, and you see the accumulation of the fluid. And most of the OCTs, they can compare the past and the new image on that. So I would definitely include that in the investigation in order to see if there is papilledema, just to have a recording, so to compare with the next visit what's going on.
Okay. Those of you that were here for the medical retina session, Stavrenia gave a very good comparison of 3 children that had macular changes. And this is another child with macular changes. So if you remember what she was saying, this will be a little bit of repetition, and I'm expecting you to really come up with the answer straight away. So this was a 13-year-old girl who, again, was just went for a routine glasses check. Her vision really is relatively normal. It's only slightly down, but she's, hypermetropic. So her vision was unchanged, but the examining optician felt that she had some macular changes. Otherwise, her general health was fairly normal and family history of nothing significant to this. So these are her fundus photographs, and you can see that there's some sort of speckly things going on there, and both maculae. So what would you do next? Fantastic. So autofluorescence, yeah? Is that what you do? Yeah. Anything else? OCT, somebody said? Of the optic nerves, did you say? Yeah? Okay. Right. Why would you want to OCT the optic nerves? Okay. Well, I would be probably more interested in the OCT of the macula, but that's fine. Let's have a look. So autofluorescence is often a lot more helpful than just looking at the eye with looking at fundoscopy, because it tends to emphasize the pathology. And I think you can see it very much more clearly that there's something abnormal going on. And it's not just here, there's a little bit out here as well. But actually, I wanted an OCT of the maculae, but I was a bit disappointed at how normal they were. I did visual fields, because I do visual fields on anybody that might have a macular problem to see how widespread the pathology is, to see if it's affecting their peripheral fields, and they're really very normal looking. So we then did electrodiagnostic tests, because we do for that, and for everybody that comes in with a macular problem, we want to know what's going on. Do you remember what Stavenia said this morning about a normal ERG? So we've got a normal ERG, and we've got an abnormal, pattern ERG. Does anybody remember what that suggests? Yeah, it's kind of pushing us towards cones, isn't it? Because what it's telling us is that the rods are working really well, and we've got that backed up with normal visual fields. So if your visual fields are normal and your full field ERG is normal, your rods are okay. Your pattern ERG is abnormal. But her vision really wasn't down that much. So this is a very sensitive test. And then we look at the VEP, and we don't want to be thrown by that, because we normally think abnormal VEP means there's something wrong with the optic nerve. But actually, in the presence of an abnormal pattern ERG, you very commonly get abnormalities in the VEP. So you have to look at the three tests in conjunction. If it's an abnormal VEP on its own, with a normal pattern ERG, then it'll be optic nerve. But if it's associated with an abnormal pattern ERG, think about the macula.
So because I know where it comes, so just to get a message here, saying that the visual acuity was fine, and accidentally you can see by doing fundoscopy that something is going wrong with the macula, both macula. So we have two options: either to keep an eye on that, or to go through, and I think the most sensitive is just to do autofluorescence and electrodiagnostic. And you see why.
Yeah. So anybody want to offer the diagnosis here? It is Stargardt's. And at the time, you might say, well, actually, just as Nikos was saying, the vision really wasn't that bad, so do we actually need to do too much at this stage? And the answer was no. We said, we think it's a macular problem that you've got, go away. And then 2.5 years later, she came back severely visually impaired. So you can see now that the vision has dropped enormously. The color vision now is abnormal. The maculae here don't actually look terribly dramatic. But the diagnosis was Stargardt's disease, And it's an important diagnosis to make because of the genetic implications, both for the child, but also for the parents if they're asking about, could I have any other affected children? So they may be thinking about having more children, and therefore it's important to discuss the risks. So it is the most common early onset macular dystrophy in children, and it is autosomal recessive. So that child is not going to have affected children herself unless she pairs up with somebody else who has the same condition, the same variant. Now, you may or may not get lipofuscin flecks present, as there are here, much more clearly seen than in the colour photograph. So don't be thrown and think that you've got to have them. But this is the absolute pathognomonic sign that you have an abnormal pattern ERG with a normal full field ERG and normal visual fields. And you may or may not be lucky enough to see the lipofuscin drusen type picture when you do your OCT. It's not always that easy when you look at macular dystrophies to diagnose them and say you've got X condition, because you do get quite overlapping phenotypes when you look. And I think the thing that's really important, so I've highlighted here the abnormal pattern ERG, but you might get that in both of these situations. But the age of onset is quite important. So in a pattern dystrophy, which looks remarkably similar, they're usually older. They usually present to you as adults. So this isn't going to be a child, generally speaking. But Stargardt's can appear later on. So it can be really quite confusing to tease out these different conditions. And this is where genetic testing can help to differentiate. So if we did genetic testing on somebody with Stargardt's, which gene would we be looking at? Absolutely, the ABCA4 gene. And we'd be looking for 2 variants because it's a recessive condition. But it's actually remarkably common not to find that second variant. It's just hard. Okay, I mean, it's a very big gene, but you don't always find that second variant. What about pattern dystrophy? What sort of gene would we be looking for there, a common one? Anybody know? So rhodopsin is a common one for a pattern dystrophy. And do you know what the inheritance pattern is? Inheritance pattern of pattern dystrophy? Well, it's usually dominant. So we're looking at really quite different counselling that we give the families. So in terms of both another child having a condition or that child being able to pass it on. So genetic testing really can massively come into its own in helping you to give a prognosis and a realistic diagnosis and likelihood of passing it on.
Before we go that, just to make a comment, because it's a good chance to highlight something else. Because we're clinicians and we have children with this sort of problems. They are visually impaired children, but the life is just in front of them. We've got technology now, we can early diagnose these problems and to support the family and the child. So we should, when I was a trainee, we had no too many things to do, but now we can. Apart from the early diagnosis, the other thing is just to support with low vision aids. And it's a part of our mission just to try to create a very nice environment and an easy way for these children to carry on with their own life, either in the school or in their community or whatever. There are optical aids. They can help, very high-tech at the moment, and also counseling. So we need to push the country and the government just to do more things about these children. I think it's a big topic to discuss, but I think it's good to comment on that. So there is a solution for them. Okay, we've got children. They are now, we follow them, and they are in a university now. They do very well. So give them a chance. It's very good to early diagnose them.
Yeah, I think that's a really good point that I didn't make, because a diagnosis is just a name at the end of the day. All of these children are just visually impaired, and they need help through school, and they need help with fitting in and being part of, you know, socializing with their friends, and they need to feel positive about their condition. And we have a psychologist associated with our eye department who help both the parents and the children to come to terms. Often it's the parents more than the child that needs the psychological input.
That's right.
So just moving on to intermittent exotropia now. So we're into strabismus. These are 5 situations where you may treat or respond in a different way depending on the age of the child and the acute or chronicity of the intermittent exotropia. So I thought it was just worth throwing these at you and then discussing intermittent exotropia, and then we'll come back to them at the end and say how we would deal with them. So briefly, they're just an increasing age order. And here we've got a recent onset intermittent exotropia in a 3-year-old who's well. Here we've got a 7-year-old complaining of occasional diplopia at school, and this is not uncommon at all. It's a very common time for them to come to you. Here we've got somebody who's developed recent headaches, and now an older child who doesn't like the cosmetic look of their intermittent exotropia. And here's somebody who's had previous surgery, but they're still 20 prism diopters divergent, and they're unhappy. So intermittent exotropia has 4 phases. And this is really, to understand this, you can then understand the symptoms that they're likely to come with. So it starts off as a distance problem and gradually becomes a near problem. So the exotropia, when they're looking in the distance, starting off as a phoria, so occasionally breaking down into atropia, and they're going to be straight at near, so it's literally just a distance problem. Those people who are just occasionally breaking down are asymptomatic, so you don't see them. They only come to you at the second stage, where they've got this tropia that's definitely there for distance, again, intermittently, and now they're developing this phoria, so tendency to diverge at near. So they're symptomatic in the distance, and the young children often close an eye. That's all you see. So they're looking in the distance, and they're sort of doing that, watching television, closing an eye, or going to the cinema, because they're getting double vision. That's why they're closing their eye. Now we're getting a little bit into the worst situation where they're definitely present for distance, but they're getting intermittently now for near as well. And they're binocular still for near, but they're suppressing. They're not binocular anymore. They've got a suppression scotoma for distance. Your aim is to try and maintain that binocularity. So you want to try and get in as quickly as you can to maintain that situation. The last one here, this is the one we would prefer not to get as far as, is where they're just divergent for near and distance, no hope of ever using those eyes together again. So we're trying to intervene at this stage. How do we assess them? Well, all the normal things: vision, refraction. They might just be a little bit myopic, and it may be that if you give them their myopic correction, their eyes straighten up. Fundoscopy, eye movements. We want to know what their angle is measuring, not just at distance and near, but at the far distance. Get them to look out the window and see if that divergence increases. Now, there's 2 little tests that we do specifically with intermittent exotropia that it's quite important to know about. The first one is we patch test, so we dissociate their eyes. So you can patch test them just by covering up one eye, and then as soon as you take it off, you measure the angle to see if it's increased. Because when you're using both eyes together and testing a child both eyes together, you have this thing called tenacious proximal fusion, which pulls them in a bit. So it sort of masks the underlying bigger angle. So by patching them and dissociating their eyes, you might see that it gets much bigger, that angle. And that helps you when you're trying to work out how much you're going to operate on and move their eyes. Okay. The other test that's important, and this is probably used more than the patch test, because a lot of people just don't have the time. They say, oh, I haven't got the time in the office to do it, patch them, let them wait for 30 minutes, is to put up a +3 diopter lens. And this is to stop them having to accommodate so much. So you remove their drive to accommodate and focus on something, and therefore you're removing that convergence. If you're taking away their drive to accommodate, you're taking away their accommodative convergence. And that should mean that when they're looking at something close to, and you put a +3 diopter lens up, their eyes are not going to be pulled in quite so much. So again, you'll uncover a bigger divergent angle. And you very commonly see this, that you measure the angle for near, and it's not too bad. Put up a +3 diopter lens and relax their eyes, and their eyes drift out. And again, it's really important to know in which children that's going to happen to for when you're trying to plan how much you're going to operate on. So you assess their suppression or their stereoscopic vision, and you're hoping they still got some. And then it's really important to ask the family and the child about those symptoms, because as you remember in those scenarios, in some cases, the child was really unhappy about the cosmesis. Because we might say, oh, it doesn't really matter, it's not that bad. But if it's making their lives miserable, then it's really important to them. Another thing that's important is to discuss the post-op risks for short-term diplopia and their potential for needing plus glasses, reading glasses, if they end up with a near ESO. So you've overcorrected the angle for near when you've done their surgery. And this is when you're alerted to that happening by them having their high ACA ratio pre-op or having the +3 lens and their angle changing dramatically. So it's important to talk about, understand how the angle might change by putting a +3 diopter lens up, and how that might then guide you with your discussion for the parents that that child is very likely to be ESO and diplopia immediately post-op, but it very commonly drifts out over those first couple of months. So not to be distressed, because they've gone, remember, from a situation of divergence to now convergence. They panic. So you have to say to them, it nearly always happens. The brain hasn't quite caught up with the fact that I've operated yet. That's how I usually phrase it. I say that brain is used to pulling the eyes in. I've now reset the position. It's still trying to pull them in. So that's why you go convergent. And then they just drift out over a couple of months. And if they're really, really upset in that first period, then I'll say just go and buy some reading glasses off the shelf. And that will help you just to have some plus glasses. So surgery, we tend to reserve for the slightly older children. So if you operate on children under 5, they need more and more operations. So we don't tend to operate on the younger children. If the distance angle is larger after your 30 minutes of patching, or when they're viewing at the far distance, then you operate on that largest consistent angle that you're measuring, or you'll be underdoing it. If the near angle is larger after the patching, the near one, that's a good surgical prognosis. And if it's larger when you put your +3 lens up, remember they're more likely to go convergent when they're looking near, because you'll slightly overdone it, and they may need reading glasses afterwards. It's all about preparing the parents and the child, if they're old enough, to understand what to expect afterwards. So orthophoria is our surgical aim. If we overcorrect them too much, if we go for ESO, then if we aim for that, then we're going to give them double vision. They won't diverge enough. The success rate is very interesting if you read papers. It very much depends on the length of the follow-up of these studies. So the longer you follow them up, the longer you find, the more common it is to find that they drift out. So we see that with 6 to 12 months follow-up, the success rate looks fantastic. If you follow them up for up to 5 years, then the success rate drops. So just briefly going through these different scenarios, what would we do with our 3-year-old who's got a recent onset intermittent exo? Well, we do fundoscopy and refraction because they may just have myopia. Remember, they're recent onset. If it's all normal with the exam and the investigations, then we just monitor them. Remember this, we avoid surgery in the under 5s. So however much those parents come and say, could you just fix it? We've noticed this, we don't like it, just fix it for me. You say, no, it won't work. You'll be coming back for many, many operations. And the other thing, actually, which I'll come on to right at the end, some of them correct on their own. They don't ever need surgery, and that's really important. So tell the parents, we could be operating on your child who might have got better on their own, so that's another reason we're going to monitor them. 7-year-old here complaining of occasional diplopia at school. Remember, they've just started to have symptoms. So in this situation, we're going to give them convergence exercises. In some countries, they use minus lenses to try to stimulate the convergence, to try to give those muscles a bit of a workout in the gym. And that's the same sort of thing we're doing really with the convergence exercises. On the whole, children hate doing them, but we always start off with them first. And they do help. If the children, if they're just starting to become diplopic and you give them the workout to do, and they do it, it does help. But now we've got somebody a bit older who's developed recent headaches. So if there's no other cause of the headaches and the intermittent eXo is present for more than 50% of the day, then consider surgery in those children. So you may have heard of something called the Newcastle score for intermittent exotropia, and that is all to do with how much it's present and how bad it is. Is it involving the distance and near? Is it present for more than 50% of the day? It doesn't make a difference to the outcome, but it might help you to decide when you're going to operate. In practical terms, though, it's if they're symptomatic, if they've got eye strain from trying to pull their eyes in, then either give them prisms in the short term if you've got a long surgical waiting list, but if you haven't, then just go ahead and operate on them. So what about the child that doesn't like their cosmesis? Well, here, why not? Just go ahead and operate on them. Why are you holding back? And then the child that's had previous surgery, so they've already had their bilateral lateral rectus recessions, and they've still got 20 diopters of divergence and they're unhappy, then go for the medial rectus resections. So just finally, it is the commonest type of exo deviation in childhood, affects about 1% of the population, and 60% of the intermittent exos are under 5. So you'll see them young, but don't operate on them young. 16% can improve spontaneously. Monitor them for their loss of stereo. That will be an indication to go and operate if they're starting to lose stereopsis or they're developing symptoms. Bilateral rectus recessions, lateral rectus recessions are the commonest operation, and look for that increase in the angle with a +3 diopter lens, because that suggests a high ACA ratio and you might overcorrect them. So warn the parents they might need to have reading glasses afterwards. Thank you.
So, the time is running. Just a couple of comments on intermittent exotropia, which is quite common